My name's Garth Parks. I'm a consultant gastroenterologist from the Royal London, and I'm joined today by...
My name's Lisa. I'm an IBD specialist nurse, also at the Royal London.
And my name's Ellie. I am a university student and an ulcerative colitis patient.
And we're here to try and chat about inflammatory bowel disease, what it's like living with inflammatory bowel disease, but not to forget that on World IBD Day, if you've got grands and granddads who want to support the charity, please can you text PURP or PERP 19 and then the pound sign with the amount. You can add as many noughts as you like to 770. So that's 70070. Right, well, we thought we'd start by chatting about what exactly inflammatory bowel disease is. And I think we agreed that I would start that a little bit. Inflammatory bowel disease, two conditions. The first being, well, Crohn's disease and ulcerative colitis. So I always think that IBD is a Ronseal disease. It does exactly what it says on the tin. It is inflamed bowel, and it's obviously a disease. So inflammation anywhere in the body leads to sort of red, angry, swollen things. So you can think about your skin when you think about inflammation, because I think that's easier for patients to understand. They've seen eczema and psoriasis, and it's a bit like that, but going on inside your bowel. The two are slightly different. Lots of treatments are quite similar between the two, and for some patients it's quite confusing because we're never quite sure initially whether you have Crohn's disease or ulcerative colitis, and I think for some people that can be quite confusing. But essentially Crohn's can affect anywhere between your mouth and your bottom, the anus, but the commonest site of Crohn's is in the small intestine, the last bit of the small intestine that we sometimes jargon as the terminal ileum, whereas colitis affects the colon. That means itis means inflammation, and col means it talks about the colon, so it affects that. They're reasonably common, but lots of people, if they really went out there and looked for it, would actually find somebody who had it, but often people don't talk about it.
I think that's one of the things that came up today was that the recent survey by Crohn's and Colitis, I think there's 10,000 members, and 95% of them said that they still feel slightly uncomfortable discussing bowels and inflammatory bowel disease, so that's why we're here.
And it's really different from things like diabetes, asthma. No one would mind saying to, oh yeah, I've got asthma and I have to take this inhaler. Yeah. But actually turning around and saying, well, I've got colitis and I need to go to the toilet more than the next person, or sometimes there's blood when I go to the toilet. I think it's a big thing, and is probably one of the reasons. But they're also slightly less common diseases. So unlike diabetes, type 2 diabetes in particular, especially as you get older, people all know someone with diabetes or high blood pressure and things like that. Heart disease, the big diseases of the Western world. Inflammatory bowel disease slightly goes under the radar, which is a bit of a shame, and why we, exactly as you say, why we're here today. Lisa, what's some of the misconceptions about IBD? We've sort of talked a bit about those, but what do you think?
Yeah, I think a lot of our patients, I mean, certainly you can tell me if you're, and when they do discuss it with people, quite often other people will say, yeah, I've got that as well, I've got irritable bowel, or, so it's kind of understanding that this is a pathological condition. It's causing sort of inflammation in the bowel. It can be quite serious, and a lot more serious than if you sort of mention it to your friends in the pub and they've got a slightly dodgy gut. Whereas you can, your joints might be affected, your eyes, your skin. So there's all those sorts of other features.
I think that the sort of the extra intestinal symptoms, if you like the eyes and the joints, is a big one actually, because I mean that's something that I've had recently, sort of inflammation of the eyes, and it's something that you wouldn't really think would be connected to your bowels.
Absolutely,
really, but it can be. So
and we do have some patients that even show up and first present with sort of sore knee or joint pain or skin problems, and it's only then that the connections are made. So I think that's a big one. I think also when we were talking earlier and we were sort of saying that quite often I find that people understand that they've got the disease or they've got the condition when they get their diagnosis, but it's sometimes not until they perhaps have their second big flare-up that it really hits home that this is something that they've got for life, and might have to make some adjustments. So that's a big thing, I think.
I think one of the last kind of misconceptions is, and it's almost the hardest, and I often turn around to family of patients, because sometimes I don't really feel, even partners, mums and dads, sometimes children as well, when it's the parent with the disease, and just say, look, living with when Crohn's or colitis is switched on, it's a bit like you've got the flu. You feel generally dreadful. You're knackered. You just want to lie down and sort of roll up under the duvet, and that kind of draining sense of fatigue that can happen when it's switched on, and unlike the flu, which might be there for 2 or 3 days and then disappears, you've got to get out of that bed and decide, well, I can't stay here all, for the rest of my life. I've got to get up, I've got to get out, I've got to try and go to university, school, work, go out and socialise, all those kinds of things. And I think that's another, because it's invisible, it's all inside. It's not like psoriasis, as we were talking about earlier, it's not on the outside. That battle is going on deep inside you.
Yeah. But then that's what we think. I mean, we're not the ones that are living with it. So, what does it mean to you? What's it?
So first off, I should probably tell my story with it. I guess just a little bit of an introduction. So, I was diagnosed when I was just turned 19. I'm 22 now. So this was back in 2013, and I'd actually had the symptoms of ulcerative colitis for nearly a year, which was probably a bad thing to keep to myself. But I think this is a prime example of how embarrassing it can be, because I was having these sort of diarrhea and bleeding going on, and I really just didn't tell anybody at the time, not even my parents or my friends, because I was 18, teenage girl, does not really want to think about her bowels, particularly coming up to the end of sixth form and then going to uni. So this sort of went on for the whole of 2013, and then I went off to uni in September, and it kind of became even easier to hide it, because I was obviously surrounded by new people who I really wasn't going to tell, and sort of my family and friends were not with me then, so they sort of didn't see me sort of getting worse, I guess. But by Christmas, I had become so unwell. I weighed about 6 stone, a bit less. I was really sort of, when I went home for Christmas, my friends that saw me were like, what has happened to you? What has uni done to you? And sort of then I finally had to admit to my family what had been going on for such a long time, and my mum was like, get yourself to the GP now. Went to the GP, and because I was so sort of severe by this point, he was like, right, you need to go to hospital now. I think you've got ulcerative colitis.
Wow, so it all happened really quickly.
Yeah, so I know one thing a lot of people with IBD have is sort of this misdiagnosis that goes on for a long time. And that must be so frustrating. I mean, I think personally I didn't have that, because by the time I went for help, it was so far gone. It was like, you've definitely got this.
I was always going to say, by the time the GP's going, not only do I know the diagnosis, but I'm going to admit you that you've taken the disease. Really, because that GP might only have 1 or 2 patients. That's worth bearing in mind. In a practice of 1 GP for 2,000 patients, that's a full-time GP. If you're half-time, you'll have less than that. The rough rule of thumb is maybe 2 or 3 patients like that. So the fact that they spotted you from a mile off and admitted you just shows how sick you were.
Yeah, so and then from being admitted, I was sort of diagnosed with a flexisigmoidoscopy, which is camera up, we know where, and immediately it was sort of noticed that I had ulcerative colitis, and over the next 2 weeks, which involved Christmas and New Year, unfortunately they were sort of treating me with steroids and immunosuppressants, but none of this worked. So 2 weeks later I had an emergency operation to remove my colon. Wow. So this was a shock to me, because I'd gone from not even knowing what IBD was to 2 weeks later having a stoma, which was unbelievably big to change, and I had to take a year out of university for this, which I've just started. But over the next couple of years, up until now, I went on to have 2 more operations, and I've now got something called a J-pouch, which I think is going to be explained in a moment. But I had a stoma for 18 months, and now I've had the pouch since December 2015. So, that hasn't actually been smooth sailing either. I've got a lot of inflammation of the pouch now, which seems ironic because it's not colon, but there we go. So that's something that I'm still dealing with now. But that's my story up to date. Wow. We were talking before about misconceptions and things.
Yes.
So I think.
What did you think was wrong with you? And how did you manage to sort of?
I don't know kind of what was going on in my head. I kind of rationalised it like, oh, it's piles. Oh, it's gastroenteritis. It's an upset stomach. Which is so ridiculous looking back on it now, because it was clearly something serious. But I think at the time, I'd got myself into this mindset of, I'm 18, I'm invincible,
I haven't got time for this.
Touch me. I haven't got time for this. And I just sort of convinced myself, because nobody in my family has IBD, so it was never something that I'd heard of or been aware of. So it was just, plough on. This is not going to be anything serious.
Were you Googling? I mean, most patients come to us and say they sort of, they've already come to a conclusion.
I did Google, actually, and it did come up with IBD, but it also said ulcerative colitis. I know it's not that rare, but it's fairly rare in the UK. So I looked at that and was like, I can't have that.
Yeah, sure.
It's just small statistics. I kind of just passed it on. And
I think the presence, you know, if there's anyone out there, and it seems, I suppose, a bit unlikely, most people watching are probably either people who've got the condition or know people with the condition, but the presence of blood in your stool, whereas it's quite common to have actually blood, all of us are, about 1 in 4 of us will have blood at some point in our stool. That doesn't mean all of those people obviously have got Crohn's or colitis, but if you've got consistent blood in your stool, that is something to go and see your doctor about.
Yeah.
And we feel quite passionately, and there's quite a big differential diagnosis. Often patients come and think, well, this is cancer, I'm for the high jump, because they see that that's in there. But the presence of diarrhea and blood together, especially blood mixed in, is really highly suggestive that your bowel is inflamed.
Yeah.
Now, actually, that doesn't necessarily mean you've got inflammatory bowel disease, because you could have an infection, and that can mimic that. The difference is that most infections go, even at their worst, after 2 or 3 weeks. So by the time you've had, in your case, an entire upper 6 year or whatever it is, year 13 these days, the fact that you're still going and still,
I think one of the difficult things, though, is so with ulcerative colitis, in some ways, even though you decided you weren't going to necessarily take that on board, there are some pretty obvious symptoms when it's when it's active. Whereas with Crohn's disease, sometimes it's not quite as obvious, and that can be really, really hard. And a few people that talk about their sort of that delayed diagnosis that you said, quite often it can be because it's not quite as in your face what's going on. So there's the fatigue, there's difficulty in eating or loss of appetite. They might have change in bowel habit. They quite often won't have blood. So a lot of those things that help our GPs to make the diagnosis aren't there for them.
And I think that's something as well. I mean, I feel completely ridiculous now looking back at 2013 and thinking, why did I not go and get this seen? But actually, when I got admitted to hospital, I said this to the gastroenterologist. I was like, how can I have left this for so long? And I remember him saying, actually, you'd be surprised how many people do leave things, because people don't want to talk about their bowels and, bleeding when they go to the toilet and stuff. It's just something that you kind of think, oh no, I'm not dealing with that. And so a lot of people, out of embarrassment. And I think that's why something like World IBD Day is so important, because that embarrassment can actually be really harmful and stop people either seeking help, but then once they've been diagnosed with a condition, stop them talking about it and feeling ashamed of it.
Definitely. So now, what do you do? You're sort of about to start university, Renee, don't you?
So literally today, I have finished my final exams at University College London. Celebrate. But I'm starting studying graduate medicine at St George's University in September. So that's the next step.
And what are you doing differently in terms of letting people know about your IBD and?
So as I've sort of gone through the surgeries and things like that, I've been quite vocal about my condition, because I really decided to myself when I had the operation as an emergency in the beginning, I was like, right, I'm not going to let embarrassment stop me anymore talking about this, because embarrassment really got me into this awful situation in the first place. So I kind of, over the past few years, have done a lot of things with Crohn's and Colitis UK, but also things like blogging and trying to raise awareness. And I've sort of shared this with my own friends, but more widely on the internet as well. Because I've just really felt quite passionate since then about raising awareness of it.
And social media is an amazing way to get that message out to so many people, whereas previously, I suppose campaigns about diseases, there are, you're trying to share this space and compete with, all the other kind of medical conditions that are out there, but it's such an easy and cheap way of getting that message out.
Definitely.
So, Lise, who gets Crohn's and colitis?
Well, you commented on they are generally sort of young adults, and people who are doing exactly what you were talking about there. So you're maybe it's last bit of school or your sixth form. You're just about to go out and start living, really. Maybe jobs, relationships, all those kind of things. So it couldn't really come at a worse time for a lot of people. I always tell medical students that this is you. Basically, you walk into my clinic and you're a new patient. They're around about your age. Obviously, some are presented in the paediatric as children, but at school age, and some will present much later. But the bulk of it are exactly like you, somewhere between the ages of 18 and 30 is probably where we see most of our new patients, unfortunately. So it is a condition. It's one of the reasons actually why it's so rewarding for us that we're not necessarily dealing with people at the extremes of age, not that
sort of particularly being ageist or anything, but the amazing physical reserve of dealing with people who are still young is that if you can get them over this, like you mentioned that you got down to, I'm a kilo fan, so you got down to about 40 odd kilos, you know, and you've gone, you know, and you can recover from that, from being really malnourished and like on not quite death's door, but you know, really struggling.
Yeah.
And now, you know, you can be as fit and strong and do whatever you want, and that ability, I think, is a huge. I don't know about you.
I know for me, it's one of the things. It's one of the rewarding things about the job that I do, and so I mean, one of the questions we were sort of thinking about was, you know, why do you end up doing IBD?
Yeah.
And I thought about it quite a lot today, and how did I end up doing that for a living? But I went into gastro when I first qualified, and then I took on a specialist job, and I was sort of given a bit of free rein to decide what to do with it, and it became really apparent quite quickly that just simple things like accessibility, continuity, somebody who kind of, you know, knows you, allows for that kind of discussion and that, you know, involvement in to take place, really. And it is so rewarding when you see somebody who is in that sort of situation and then goes on to achieve so much. And I've got nothing but respect for all of our patients, actually, who really do get up every day and just go out there and do their best with the conditions. So I think it's fantastic that I can do a little bit, hopefully, to help them to do that.
Definitely.
Yeah.
I think what you're saying about people sort of getting up and getting on with their day, I think that's the biggest thing, is that even if you're not having a flare, you can sort of have this tiredness that sort of seems to go on a lot. And I think I've found still with problems I have with my pouch, it's kind of, I get extremely tired on some days, and some days I just don't want to get out of bed at all. And you sort of have to fight through that because life doesn't stop around you. You just have to sort of say, right, and it's not the sort of tiredness that's like, oh, I need another night's sleep. It's just this awful kind of dragging through a fog kind of tiredness. And that, in some ways, is even harder, I think, than some of the bowel symptoms, because that's something constantly, all day, affecting you.
Yeah. And for a long time, it's been there's been this sort of fear of Pandora's box. So when you go for your appointments, people won't ask you about tiredness. They won't necessarily want to talk to you about diet and things like that, because there aren't these.
We don't have easy solutions.
Easy answers.
And so we say, how many times do you open your bowels? What's your weight? I do that. And then, you know, is there any blood? No. Well, then you must be, by definition, because all these things are fine. You're amazing. And actually you're going, hold on, I don't feel amazing at all. I feel dreadful.
Still feel,
And I think the fatigue, well, we touched on it before, but the fatigue issue is really hard, and it's really difficult, and it is multifactorial, and trying to think of solutions.
I mean, I know that Crohn's and Colitis are doing a lot of work at the moment now. So they've already done some work on fatigue. I know there was a bit of feedback that to begin with, that, you know, there was a fatigue tool, and the general feeling was, I've done this tool, I've worked it out, and I'm knackered. Now what? I could have told you that, but you know, it's just the beginning of that sort of stuff. And I think there's lots of opportunities for people with inflammatory bowel disease to get involved in that research. So into fatigue, we've just been involved in a continence study as well. Diet is now something that's been looked at. So, and not just necessarily what to eat or how to eat, because that is one of those things that's got really, you know, there aren't any particularly easy answers, but rather than how does diet affect your Crohn's disease or your ulcerative colitis, how does your IBD affect your diet? So does it stop you from going out? Does it stop you from, you know, sort of being out with people, you know, having fun, doing all the things that you should be doing when you're just about to start medical school. So there's lots and lots of opportunities. I think Crohn's and Colitis are always looking for people to, because you've done quite a lot of fundraising and stuff with them, haven't you?
Yeah, I mean, over the years, I mean, right from the beginning, when I was admitted to hospital and diagnosed, having not known what this condition was, the very first thing that I was given was a Crohn's and Colitis UK leaflet. So that was my first point of call. And I think that really later on made me want to get involved with the charity, because that was sort of the first piece of information I received. So I've done a lot of things over the years with sort of social media. I'm on the readers panel at the moment, so I sort of read leaflets that are going to be sent out and give my views on them. I've written a couple of articles for Connect, and I've done various other events related to media and sort of better awareness in the press. I did an event a couple of years ago to do with that. So, you know, I really like getting involved because it helps keep things current and sort of give something back, I think, because this charity's done a lot for me over the years.
Yeah. I I mean, I know I certainly still use, they make my life a lot easier because all the information leaflets and things I tend to go for Crohn's and colitis, so it saves us having to rewrite them.
Yeah, and there are all sorts of ways in which you can sort of tie into the charity, you know, through running and all of those, the big walk-in, I'm looking over there, the walk-it, which will be coming up later on. I just wanted to talk a little bit about treatments because you're almost the worst patient in the world for doing about treatments. But, as a physician, as a gastroenterologist, most patients with Crohn's colitis be looked after by a gastroenterologist, by someone like me and Lisa as a specialist nurse. And our job is to try and keep them away from surgeons as much as we can.
Not
Well, not
to try and work in a...
We work together, clearly. Yeah, I mean, there are lots of treatments that, unfortunately, with you, they just didn't work, and that can sometimes happen. But there are kind of range, and at the moment, I have to say, if we were going to be a bit positive about things, compared to 5 years ago or 6 years ago, when really we had no new medications in quite a long time, it's quite an exciting time at the moment. We've got conventional medications, which you've probably heard about. So there are anti-inflammatory 5-SA drugs, in particular in colitis, and those are for patients with mild and moderate disease. And then we go through steroids and things like that, which you need for flares occasionally, where we try and avoid them as much as we can. And then moving through into immunomodulators, which you possibly got towards that. And then biologic drugs, which are the sort of exciting development, first came around about 15 years ago. But we only really have one class for a long time. And then just recently we've had a second and now a third class, and there are more in the pipeline. So actually for the first time, and we're even getting treatments for pouchitis, which has been a totally overlooked condition for years. The first big trials are now happening in pouchitis 2. You know, you'll wait for buses.
I'm on one of those.
Well,
actually, yes, I can do one of those. Yeah.
And being part of research, and it's something that Crohn's colitis has been really key in, and whether it's clinical trials, there's a huge amount out there. And I think asking your physician whether or not there are any trials that are ongoing in wherever you are is really important, because it may not be there, but we tend to work in networks with other hospitals. So if you're at a smaller DGH, you might have a fantastic gastroenterologist, but who doesn't quite have the time. You know, being referred up to the bigger centre just for the trial, and then you can always go back. But all of those things are possible, and I think, you know, it's a really exciting. Well, exciting is perhaps the wrong word for it, but the whole field is changing quite a lot at the moment, and that's only for the good. And again, it's been campaigning actually by the charity and others to get some of these drugs funded, because unfortunately some of the bigger ones, the biologics, are quite expensive, and getting those through has been really important.
Do you think that sort of idea of going to a different hospital, I mean, obviously that's something you might be dealing with now
It
because
might
you're
well
moving.
be, yeah.
But if you've got a good setup at the hospital that you're at, do you think that moving to another hospital, even if it is for a trial, can be quite nerve-wracking, quite daunting? Or
I think it could be, because, I mean, my gastroenterologist and my surgeon, they're both fantastic. I can't praise them more highly. And I have a great sort of relationship with my gastroenterologist, who has sort of seen me from the beginning, literally diagnosed me with the condition, and I still see him now. And I think, you know, studying in London for the next 4 years, who knows, I might end up moving here. I don't really know what's happening yet, but I think that would be quite difficult to go from, especially the hospital where I was first diagnosed and first treated, to a completely new team, because there's always that worry, even if it's just temporary, like you say, for a trial, it's always that worry, you know, they don't know me, they don't know my condition and how it's progressed, and sort of, you know, is anything going to be missed, you know?
Absolutely.
So
and can you think of anything that might make that better, make that easier, or
I just, you know, maybe going along prepared to the new team with a list of things that you think are really important that they know. You know, even if your medical notes have been transferred over, just for your own peace of mind, if there's things that you want them to know, and make sure that they know, maybe go yourself with sort of a list of things to say, this is me, this is...
armed with, this is what's important to me right now. And
definitely.
I think there's a really big unmet need. We've worked a lot. Charlie and Kay were talking earlier about transition and moving from being a child with inflammatory bowel disease through to being an adult, and that transition often from a paediatric team through to an adult team can be really tough. But we've never talked about the transition from being under one team to another as an adult. And this is a condition that affects people like you, so they move all the time. So we live in the, I work in and live in the East End of London, we both work there. We have a massive amount of sort of, migration's the wrong word, but just people moving in and out of London. They sort of, come down for a few years or study there, just as you are. You're a really good example. So we have this massively high turnover, and to try and build that relationship, I think it's really important.
Yeah.
We're possibly straying into it's an unmet need.
Yeah.
Definitely. Yeah.
Now, have we got any questions? We have got some questions.
Oh.
Aha. So, is a diet, Joe has asked, is diet a must from having IBD, or does it affect everyone differently? Do you want to do that one?
Yes, unfortunately it does affect everybody differently, and that is one of the biggest challenges. So as we were saying earlier, there's how diet affects you and how it affects your Crohn's disease or your ulcerative colitis. Some patients benefit from sort of low fibre diet. Some patients will benefit from what we call stricture diets if they've got Crohn's disease in particular, and if they've got narrow bits in the bowel. There is quite a lot of work being done at the moment in diet. So as well as all the medicines, there's a lot of interest in diet and trying to see if we can find certain groups that would benefit from certain kind of diets. But there isn't really a one size fits all. And I think you've got to be quite careful not to really restrict your diet either.
So there are some conditions like celiac disease that we would treat purely by being on a gluten-free diet. So gastroenterologists, are really keen. If there was a diet that worked for this, we'd be using it for about the first 30 years before we invented any medications for this. People tried to control it really badly with diet in the sort of 1930s and 40s. But in particular with colitis, there's probably no universal trigger foods. Perhaps chili, alcohol in quite high amounts is a really common one. People often say if they've been out and had a few pints the night, or lots of pints the night before, they really know about
if I go out and have a few
pints. So chili is the obvious one in which anybody can have diarrhoea. So those are kind of universals. But apart from that, it's really what affects you. And I think it's the commonest thing in the world for patients to feel like this must be something that I'm eating that's driving this. The only control I've got over this is by what I put in my mouth. So it must be, if I just choose the right food. And I think that then really affects quality of life, because you have a bad day and you think, well, it was onions, so I'll cut all onions out, and the next day you have it's broccoli. And before you know it, you're eating almost nothing at all. You're on this dreadful, restricted diet. And I think part of our job to educate people is to try and open it up and allow more. Right, what other questions have we got? Right, Nicole says, any advice for someone who is about to go through surgery for an ileostomy? Wow.
Gotta be you, Ellie.
That's gonna be you.
Okay, so first off, hi Nicole. If you are coming up to having surgery, I really wish you the best. I hope it all goes well. I think obviously it's such a daunting thing to be sort of told you'll need a stoma, and I think particularly for someone either approaching it from an emergency situation like I was, I think that's hard because it's a shock. It's, oh, you're having a stoma now, and no choice about it. But it's also just as hard for someone who has to go through the long term, like, oh, should I have it? Should I not have it?
Yeah, absolutely.
Both have different problems for people. So I think the first thing to sort of really promote is that it will make you feel a lot better to have an ileostomy, as much as you probably don't want to have one. I remember as soon as I had one, I really noticed a difference within a couple of weeks. Even though I was still so weak from the surgery, it was kind of just that relief of not having to dash to the toilet all the time. That had gone from the beginning. Yeah. And I think also with a stoma, people worry, how am I going to deal with sort of changing the bag? And, there's so many concerns that people have, like, will people be able to smell me with an ileostomy? That is something that people really, can think, but that's not true at all. The bags that they have now are completely sealed, and there's no sort of, no one can tell that you have a stoma unless you choose to tell them. So I remember I could pretty much wear all the same clothes that I wanted to. I went and got myself some kind of spandex. There's a great website called Comfizz, which is sort of, they're a bit like spandex, but they're meant for people with stomas, so they kind of help flatten everything if you want to wear sort of tight dresses or things like that still. But I think, just preparing yourself, I mean, it is very hard. It's a very hard thing to go through. No one's going to deny that. But I think actually it's something that you become used to very quickly. It's kind of like when I first had a stoma, it took me about 15 minutes to change each bag, and I thought, oh my goodness, is this going to be what it's like for the rest of
This is me,
ever? But actually, a couple of months in, it was like 2 minutes on and off, and in the morning I get up, I brush my teeth, I have a shower, I change my bag. It was just part of my daily routine. And it's just something that kind of becomes part of your life, and you just sort of get used to having it.
Did you have a support network of people who you sort of let into this thing? And do you wish afterwards you made it bigger or smaller, or how do you break it, because it's so big?
So I think that is such a personal thing as well, who you choose to tell. I mean, some people are very open about having a stoma, and they don't mind anybody knowing. Other people, literally nobody knows apart from maybe the very closest people to them. I mean, I personally told my close friends, and as I was at uni at the time, the housemates I was living with, because I kind of, I was having all my equipment in the bathroom and things. I didn't want any questions about that. So, told them, and sort of some close friends. A lot of people knew I'd had surgery, but not necessarily what that involved.
Yeah, sure.
And I some people actually went away and read about it and then came to me and said, oh, so you have a bag? And at that point I wasn't going to lie. I was like, yeah, I do, because I think it is important to sort of be open about it. So yeah, I mean, I just sort of told people close to me, and then sort of some people that if they asked, I would just say, but otherwise than that, I didn't tell people other than that, apart from on social media, usually, which was, so...
Get it all out
Actually, so on that note, on the Crohn's and colitis side of things, I was blogging, which my own friends personally wouldn't necessarily read, but I didn't mind sort of sharing it with the Crohn's and colitis community, because I felt...
And were those closed groups, or were those just to anyone?
I shared it a lot at first on the Crohn's and Colitis UK forum, which is a closed group. But then after a while I started my own blog, which is accessible to anyone. My friends didn't necessarily all know about it, but if they found it, they would do. But on there I was very open about having a bag, and would post photos and things like that as well. So
Okay. Right, other questions. We've got a question for me and you, Liz, from Lauren. Hi, Lauren. Why, after lots of cameras, I thought you were talking about this one, and tests, is it still not known whether someone has Crohn's or colitis? That's a really good question. That one's possibly for me. In particular, so sometimes it's really obvious is the answer. So if you've got disease, for example, in your small intestine, we can see it, it's really easily there, it's visible with a camera. As soon as we go round, we know the ulcers are there. Then almost certainly you've got Crohn's disease. And that's because colitis will almost never affect that part of the small intestine. So if you've got disease there, and you might have had an MRI as well, then we know exactly what's going on. If you've got disease confined to the colon, then it can be a bit hard, because it could be Crohn's colitis, or it could be ulcerative colitis. Now, there are a few things that tell us whether it's one thing or the other. It actually doesn't make an enormous difference to your medications, because a lot of the medications we use are very, very similar. And actually now we've got broader licenses, so some medications which were confined for Crohn's use only, the more expensive ones, have now got use in UC as well. So that can allow us, and we've even got this kind of slightly, it used to be called IBDU, or unclassified, or uncertain etiology, where we sort of hedge our bets. The answer is, if you've got colitis, you can occasionally later on down the line be reclassified as Crohn's, and I'm afraid that's just because diseases don't come with a big flag on them saying this is what I am. And the answer is actually even more complicated than that. We know there are hundreds of genes that are potentially involved, and there's probably a bit of a spectrum between those patients who have got really clear-cut Crohn's, mostly affecting the small bowel, all the way through to those patients who have colitis, and they're on more of a spectrum than we think. These labels were essentially made almost 100 years ago.
I always say I think that Dr. Crohn takes the credit for quite a lot of illnesses, really.
There were 3 of them, and Crohn's in particular. Yeah, why have some people got mouth involvement, some people have got involvement around the back passage, other people it's just confined alone. And there's a broad spectrum of how severe they can be. Right, some more. Right, this is a question for Ellie. I'm jumping from Anna. Do you have any tips on anxiety?
So I think, I guess when we're talking about anxiety, that can, apply to a lot of different things. So the anxiety of perhaps going out of the house and being worried about not being able to find toilets and sort of worrying about the physical symptoms. But also I think this condition generally can make you anxious, as in it is, you know, a condition that you have for life, and I think that comes with a lot of worry, sort of how is this going to be in the future? How is this going to affect me? You know, because it's such an unpredictable disease as well, with its flares and things, that itself causes anxiousness because you're sort of wondering when's it next going to happen. I think tips for dealing with anxiety, I think it's really important to make sure that you have somebody who you can talk to about these sort of feelings, whether that's somebody on a personal level, sort of friends and family, that you can be really open with and say, look, I'm really not feeling okay at the moment, can I talk to you about this? Or, you know, if you have a close relationship with your doctor, or, you know, that's again another way that you can sort of talk about how you're feeling. I think, you know, on a day-to-day basis, sort of, is having confidence with IBD can be really hard to get, and I think another really good thing actually for dealing with anxiety is to talk to other people with the condition and sort of ask how they manage things on a day-to-day basis, because I think the forum that Crohn's and Colitis UK run is really helpful for that. It's sort of a place where you can go anonymously, really. I know you're using your Facebook account, but you know, nobody knows who you are on there. You can sort of go and ask a question and sort of be completely open, and it's a way of getting people to give all their views on that. So, you know, I guess my answer to that question would be sort of making sure you have a support network around you who understands what you're going through and can help you with that. That's fine.
And it can be quite complex because the disease, obviously, the more active the disease and the worse the urgency and things like that, that can definitely feed in to anxiety. And urgency is probably the most debilitating, the single most debilitating symptom to like preventing, or you know, the highest impact on quality of life. And one way of trying to get over that, if you can see, you can become a member of Crohn's and Colitis UK, and with this membership card you get a urgent it can't wait, which is essentially something you can at least hand to owners of toilets in order that you need to use the facility. And this thing, which is even better, and that they've been talking about all day, this is the magic key, this is the radar key that it doesn't get you into kind of Narnia or Harry Potter's into Hogwarts, but it does get you into disabled toilets. And often you'll find that disabled toilets a lot, but this is a universal key, will get you into any one of them, and by becoming a Crohn's and Colitis UK member, you can apply for one of these. And that kind of confidence that you can get out of the house. And also come and talk to your physician or talk to your nurse, because if your disease isn't under control and the urgency is not under control, then it's really hard. Because with a pouch, I mean, you're still, I'm going to be a bit personal and say, it's really common to go to the toilet several times, but if the pouch is good, and I know you're having problems at the moment, if the pouch is good, then you lose the urgency. If the pouch is inflamed, then the urgency comes back again. But yeah, urgency is trying to get on top of that.
I often talk to people and say what we really want to do and what we're trying to achieve is to make you a person who just happens to have inflammatory bowel disease. And I think if the anxiety and that's around symptoms in particular is so intense that you're being defined by it, then we're not really doing our job properly. And whatever that needs, whatever that next step is to try and get you back to sort of having your life that just happens to have that IBD with it, we need to sort of take it together, because it shouldn't be governing you. You should be living with it there. That's the aim, really.
And I think that is a big thing, actually. I think because a lot of people with these conditions spend so much time in and out of hospital or, you know, seeing doctors, it's just, you kind of feel sometimes like your life becomes IBD, which is not what you want. And I think that is sometimes something that's got to me over the years, because it has been such an intense couple of years. And it's sort of, sometimes I feel a bit like my life's been defined by IBD, and at that point I have to remind myself, no, there's so many other things that you've done in these 3 years that are not related to that.
Absolutely.
You know, but sometimes if you're feeling down, you can end up thinking, oh, this has dominated my life for, you know, for me it's sort of, I guess what's meant to be the wildest time of your life, your like late teens, early 20s, has sort of been, I guess, dominated by this condition, which is sometimes really hard to deal
Yeah.
with.
If
But
it helps Lisa continues to be wild,
Yeah.
way beyond her 20s.
You're never too old to be wild. I mean,
Yeah.
I'm 21 and I
Yeah,
still
exactly.
go out
Yeah.
occasionally.
Yeah.
Right, we've got one last question perhaps. Right, this one is for me and Lisa from Bex. Hi Bex. Can IBD, medication and surgery affect fertility? Well, that's a brilliant question and a really common one, and one I'm sure Ellie might be thinking about. So,
Yeah.
Lisa?
Well, I can start with the medication
Yeah.
side of things. So our general rule of thumb with IBD medication is that it's better to have you as well controlled as you can be, so that you've got more chance to A, do the sorts of things that you need to do in order to get pregnant, or make someone pregnant, and B, give that pregnancy the best chance of kind of, going full term. So with a couple of exceptions, methotrexate being one of them, that's really obvious and is really harmful to babies. We tend to sort of suggest that people stay on their medication. If we've got people on biological drugs, sometimes if you're very, very well and you're sort of going into your third trimester of pregnancy, we might suggest that we try withholding the drug because it does cross into the placenta. But otherwise we would sort of carry on treatment. And in terms of fertility itself, we would definitely try and keep you in remission, and that helps to boost it.
Yeah, there's one other exception to that. It's pretty old-fashioned and almost very few. Well, there you go. Thalidomide we use very little, but sulfasalazine, which some patients might be on, it's particularly used for joints. But sulfasalazine is an amazing male contraception. You cannot buy it over the counter, but your swimmers will not swim with sulfasalazine. As soon as you stop it, they'll be absolutely fine. So it's not a permanent thing. Some blokes, just even at the mere mention that they might be temporarily medically infertile, don't like it. But if you're on sulfasalazine as a bloke, and every now and then people talk about people who go all the way to fertility treatment, that is an absolute no-no. All you got to do is stop that medication.
There has been the odd paper around azathioprine as well, hasn't there? But I think that's been disproved.
Yeah, there's a lot of fear and a lot of concern, and it's completely normal. So that's sort of moving away from fertility to actually you are pregnant. And it's completely understandable. These are drugs that are in heavy doses are used almost as chemotherapy agents, and how could it be all right to take this when you're pregnant? But the answer is that tens of thousands of patients have now, both with inflammatory bowel disease, but also things like kidney transplants and liver transplants, where you absolutely can't come off the medication. You have to be on it because otherwise you'll reject the organ. And it's been shown to be really safe. And and sadly, there are always going to be fetal abnormalities. There are always going to be miscarriages. But there's been huge numbers of studies looking at, as I say, these enormous figures, and that there's no difference between the two. And that's what, the miscarriages are really common, and it's really easy to think it's because of that.
And what about the surgery?
The surgery, yeah, sure.
yeah.
So, historically, there was definitely data out there suggesting that this funny word called fecundity, which means that you are fertile, the eggs are absolutely fine, but the ability to become pregnant can become affected by pelvic surgery, in particular in women, but actually also in men to some degree, although in that case it's their fertility. Things have got much better these days, and in particular because we've centralised where we do pouch surgery. So whereas before it was seen as a kind of, pouch surgery has only been around for about 30 years, first invented at a place called St Mark's, and it was then sort of became quite widespread, and everyone might do one a year, and it's now realised that actually if you use a surgeon who's really experienced in that, and I think you should ask your surgeon how many of these they do and how experienced they are with them, because in skilled surgical hands that the impact on that has been greatly reduced. And obviously, they are big decisions, but you are where you are. You're facing those hurdles where you are, and you've got to deal with that hurdle first, and then you deal with the next hurdle afterwards.
I think that's the thing. I mean, just a quick point on my view. I mean, I was told when I had the pouch surgery that it would affect my fertility in some way, and I was warned about that. Do you want to go ahead? I had the stoma at that point, but it was the decision. Do I want to go ahead with the pouch? And I said, I'm 20 when I'm having this operation. I don't want kids for, many years yet. I need to live for now. So that was my choice, but other people might think differently.
Yeah.
But,
which kind of reminds us that we did promise to come back and
yes.
say what's... so for our last question from Ali, thanks for reminding us, what is the difference between a stoma and a J pouch? And I think we put you on the spot for that, haven't we?
Sorry about that. So I'm going to get a bit technical. A stoma
You've got about 2 minutes, I think.
where we bring the bowel out and we make a small incision in the abdominal wall. So instead of your faeces coming down through to the anus, to your back passage, it would come out on either side, depending on where it is. Actually, it can be quite confusing. You can have a colostomy and an ileostomy. It just means whether it's the large or small bowel that's brought out. And you bring the bowel out through this little hole. You then actually fold it back on itself and stitch it back onto the skin. And then you can place a bag onto that spout that's made. A J pouch is where we take a loop of that small intestine. So now that's in patients who've had all their colon removed and you've just got the anus down the bottom, and you bring a loop of your small intestine. Your small intestine's about 4 or 5 metres long, so you've got lots of it to spare, and you bring it down and you bring it back up on itself. So you form a little J, you staple off at the top here, and then you open up these 2 loops of bowel that have been held together, and you open them up like that, so that they become a reservoir or a pouch. And then this bit down at the bottom gets stitched or stapled down onto a little cuff of the rectal mucosa, which is the last bit of the large bowel, and the 2 get joined up together. Mm-hmm. And often patients will actually still have a stoma initially after the formation of that. So it's a so-called 3-stage operation. One to remove the large bowel and bring out a stoma. The next one to form the J pouch, but still cover it with the stoma. That means higher up, the faeces will still come into a bag. And then finally that gets reversed. And you know what? I was working with one of our registrars and she didn't know the 3 stages of a J pouch operation. So it is common. These are reasonably uncommon operations for even medics. And you might have to be explaining to a junior doctor exactly what it is, what your J pouch is.
That's happened.
And you're about to go to medical school and find out that loads of people there don't necessarily know. And trying to get that across is really important. Right. That's it.
Amazing.
So we just want to say a massive thank you to everyone who's, if anyone is out there at all, thank you for tuning in and for seeing us today, and for everyone who's been involved in World IBD Day. It's been an enormous success. We hope you can go out there and promote a bit more about inflammatory bowel disease, Crohn's and colitis. Remember about those donations if you want to. It's PERP 19 and then the # with the amount that you want to donate. And we hope you have a fantastic weekend.
Thank you.
Thank you very much.